looks like we've got a few people all on board now, which is terrific, and welcome. Thanks for coming along and joining us for what is the second in a series of webinars that Western Health Foundation is hosting for some of our supporters and donors. So I just want to say, firstly, there's a number of you who are tuning in today who are donors to Western Health Foundation, and really appreciate your support. Thank you for that. And it's great that we're able to share some of this information with you, with some of our amazing staff that we've got here at Western Health and some of the experiences that they've been through and that they've contributed to this year. My name is Julia White. I'm the Director of Western Health Foundation. I'll start by acknowledging the traditional owners of the lands on which Western Health operates, and that's the Boonwurrung and Waiwurrung people of the Kulin Nation. And I'll pay my and our respects to any of the elders who are present, past, present, and emerging. Really happy to have such a strong group of our Western Health staff joining us here today, and I'll introduce them in a moment. There's a lot of really interesting insight into what they'll discuss here as we go along. This session will run for about an hour. Your microphones and videos as viewers have been turned off, but you will have an opportunity to ask questions as we go along. We'll run a little bit of a conversation initially, and then there will be an opportunity for you to submit questions. There's a Q&A button at the bottom of your screen in the middle there. If you click on that, you can type in the questions there. You can do them at any stage during the conversation, and we'll capture that and make sure it gets fed into the Q&A at the end if it's not answered immediately. If you do have any other technical issues or any concerns, there was a phone number that was supplied on that email, or you can type it into the Q&A and we'll respond to that there. So thank you again, and I'm going to hand over in a moment to the panel. I will introduce them to you all, and we're really very happy this evening to have with us Russell Harrison, who's the Chief Executive of Western Health, Ainslie Senz, Dr. Ainslie Senz, who's the Director of our Footscray Hospital Emergency Department, Chantelle who is the Acting Nurse Unit Manager in the Short Stay Unit. And Chantelle, I'm sorry, I should have checked first whether it was Sunshine or Footscray, but within our emergency team. We were also hoping to have Dr. Marion Kainer join us, and I think she might have been on the invitation. Unfortunately, there's quite a bit of conflicting demands on her time as an amazing expert in infectious diseases at the moment, and so we've had to accept her apologies for this evening. But I know that the team here will do an exceptional job of covering the areas that she knows about. So I will hand over now to Sue Ellen Bruce. Sue is our Executive Director of People, Culture and Communications and part of the leadership team here at Western Health. And Sue will be moderating the conversation this evening. So thank you, Sue, and over to you. Thanks.
Yeah, thanks, Julia. Thanks for the introduction, and welcome everybody to our webinar. Today, I'll just give a little bit of context and background before we get started, because you will be wanting to listen to our great clinicians and to our CEO. But it's important to have a bit of understanding, and Western Health has been in quite a unique position during COVID, surrounded by a number of the hotspot postcodes, and certainly in the second wave, we really understood the impact of COVID on health services. And also it was important to probably understand that many of our healthcare workers actually live and work in the same areas. So for us, it was compounding concerns. During the second wave, or by the end of the second wave, Western Health had actually cared for over 400 COVID positive patients, and that we had cared for over 70 COVID positive patients in our ICUs. So we certainly understood what COVID meant to our patients, to our community, and to our healthcare workers. And today our panel will share some of our insights and learnings with you. And I have heard the phrase, it's like building a plane while flying it at the same time. And it sort of gives you a little bit of context about what some of our responses have had to be like, and how we've had to learn as we go and manage and reset constantly. So to set the scene, if I ask Russell, you know, in the early days when we started to hear the word COVID or coronavirus, we were fortunate to have the insights of our infectious disease expert, Dr. Marion Kainer, who had been in a similar position in America during the SARS outbreak. And lucky for us, it started at Western Health about 6 months before this happened. Maybe she didn't feel so lucky at the beginning, but we have really benefited from her knowledge. But Russell, from your perspective, what did you start to think about when we started hearing all about coronavirus?
I think, Sue, it's probably worth saying dynamic and changeable were the two words that spring to mind, because it felt like every day and every hour of your day, back in sort of late February, early March, things were changing from sort of, different countries being not allowed to fly into Australia, to that changing, to, different messaging coming out. So, it was a pretty uncertain time, and a lot of staff at Western Health had contacts internationally and were sort of watching what was happening in Europe and the US with kind of growing concern and, a lot of fear. So I think, at Western, we took a small team offline in sort of early February to plan for what was potentially coming, and Marion was involved in that. We had infection prevention staff, nurses, operational people as a small group to look at what our plans told us and what might actually come. And I think we went through lots of bits of paper and lots of sticky notes because it kept changing pretty quickly. But I think, we came up with a plan and a few scenarios, and then went to work on communicating that to the organisation. And I think importantly, we took the decision to communicate that out to our community as well. And I think we were sharing that with our staff and our patients and our community as to what might come and preparing accordingly. And the good news is, as Marion would say if she was here, we prepared for the worst and hoped for the best. And I think in that wave one, we only really had, we had about 2 patients, I think, that were COVID positive and a couple of staff that developed COVID. But overall, it was a kind of non-event that we got slightly giddy about and a little bit relaxed. And then we kind of got the second wave, which we were very quickly able to get ready for because we had all those plans in place and kept working on them. And I think that's a credit to Marion and to others involved in that process, that we never turned it off. We just scaled it up and down as we needed to. But it was certainly very dynamic and fast moving, as the phrase of the day went.
Great, thanks, Russell. And so, Ainslie, if I go to you and say, so what were you starting to think about, and what were you starting to put in place, both in thought and in actions, regarding how the ED was going to respond to COVID?
Yeah, so it was a very challenging time, and I agree with Russell that uncertainty was a big one, and dynamic was the other one. We didn't know what to expect, and we saw everything online and from our colleagues overseas to be inundated. So we had to prepare 3 arms of our emergency department. So one was the staff arm, both in terms of how many staff would we actually need. Can we upskill other staff in the hospital to come and help us in the emergency department? How many staff are going to get sick? Because that was actually part of the problem overseas, and the messaging we were getting was high rates of healthcare worker infection. So how we were going to protect our staff as well. The second arm was just about how we were going to manage the patients. And one of the things that we learned quite early on that we hadn't expected was we sort of thinking that COVID would sort of come with, COVID stamped on the forehead. And everything we saw online and overseas was that these people in terrible breathing problems lining emergency departments everywhere. And what we learned very early on is actually that's not how people came to emergency with COVID. And so we had to flip very quickly into just looking at COVID risk. And we made a very deliberate decision to stream our departments into 2 areas. One was high risk and one was low risk. And we were very clear that there was no such thing as no risk in our emergency departments, because we knew that people could have COVID without having symptoms and could have COVID without really identifying where they got it from. So there was a high risk area and a low risk area, and we still have that now. Even though the COVID in the community is quite low or 0, we still have our high and low risk areas. And then we had to think about, gosh, how much space do we need? And we actually moved half of our department up to the 3rd floor. And if you know anything about emergency, 3 floors away is not usually how we work. So that was really challenging, both for staff and also for how to, we're not used to managing people that far away. We're quite used to having people right around the corner. And so that was quite challenging for the way that we make decisions about risk. And we also had to think about how we're going to manage these sick patients that we've never seen before. They're so incredibly unwell from what we were hearing, and what are the processes that we need, and what are the equipment that we need, and what's the space that we need. And all of that happened just on a daily basis. There was a change, and actually, like, reflecting, we did an incredible job, because we didn't really have a roadmap for this. None of us had ever really done it before. And we've come out the other end with some really firm processes that can be used and applied to anything moving forward.
Great, thanks. So really the expression about building the plane while you're flying it was probably pretty true for you guys in emergency department.
Very, very true. And also changing direction and destination at the flip of a hat, like literally. Usually Friday afternoon, if we all giggle about that, but usually Friday afternoon was when the destination changed.
Yeah, good on you. And Chantelle, I know that you took on the leadership role in the short stay unit at Footscray. So do you want to tell us a little bit about how you found that and how you worked with your team? And you were the department that was three levels away from the emergency department. So how did that feel?
Correct. So I was actually lucky enough to get a holiday before COVID struck. I was in India and oblivious to all that was going on early in the year. I returned from that trip, and I remember sitting with Marion, our infectious disease expert, around the boardroom when we were allowed to share rooms and allowed to be in the same room, and hearing about the coronavirus for the first time. Very quickly, I was asked to come off my clinical duties. So I'm usually a associate unit manager in the emergency department, just running the daily shifts. And I was given the task of setting up a ward to move our short stay ward 3 floors up, and to turn what was an aged care ward into a 20-bed emergency short stay unit. I was given about 3 to 5 days. Obviously, with the rapid evolving nature of the coronavirus, we weren't given the luxury of time. So that was a very interesting experience. And obviously we couldn't have done it without the support of, the emergency department and our leadership team at Footscray. It felt, although that we didn't have a lot of time, we really had, prepared as much as we could, had the support of everyone to help us get there in a really, really quick turnaround time. And that meant, the equipment that was, some of it donated, some of it we had, in the hospital already. And it really just gave us the ability to create space in the emergency department should we have this, surge in demand for patients. We had to set up, really quick education programs. So being an emergency department nurse or doctor doesn't happen overnight. We do a fair bit of training, and, there takes some skill involved in that. And part of my role was to upskill nurses that had probably been on the ward or in a theatre environment to, to give them a bit of a crash course on emergency nursing. And also part of it was just supporting our emergency staff as well. Some of them, it was a really scary time. Some of them, there was a real unknown and fear about the virus itself. I remember having chats with some of our staff that were separating themselves from their family. Some people were taking up, hotel rooms. Some people were sending their children and partners away to live with their parents. So, in all of this, just the human factor associated with it was something that I'll never really forget, apart from all the, the infrastructure and environment things that came along with that. And I think that's one of the things that will stand out to me forever, really.
Thank you for sharing that, Chantelle. So the first wave, to say, came, and as Russell gave some context, it wasn't what we thought, or we were lucky, however we wanted to maybe term that. But then we found ourselves in the second wave. And so how do you manage a busy emergency department that's dealing with lots of other issues and COVID at the same time? Did that take a bit of resetting of thinking? How did you approach that, Ainslie?
I think the thing we learnt really quickly in the second wave was about protecting ourselves. And that's when we had a little blip of staff infection that we're not really sure where it came from. As we all know, most of us live in the West as well. But that made us incredibly vigilant. And then actually the way we managed the second wave was because we put up structures in place. We put our low risk and high risk zones in place, and we just continued them. And they really worked very, very well for us during that second wave. And so again, that principle of not having anything as no risk, but only having low risk and high risk worked very well for us. We also made sure that all the staff were in the same PPE, so therefore it didn't really matter where you walked in the emergency department, you were all protected. And we had very clear systems on how to categorise patients for COVID risk at the end. So the low risk, high risk was for how you enter the emergency department, but then we had to put people into low risk and high risk and no risk and confirmed at the end of their emergency department process, and we had very clear structures on how to do that as well. So actually all the systems that we had created served us very, very well for moving through that second wave. I think, as Chantelle says, the biggest problem with the second wave was actually that we were all in it as well as individuals in the community, and we were tired of lockdown, and our families were doing remote schooling, and everything was happening to us as people in the community. And that was the thing that took its toll. I think we all can do our job and we know exactly what that is, but the personal element of that really took its toll.
Yeah, thank you. And Chantelle, from a nursing perspective, so did it change the way nurses did their practice, or was it just another element from what you were doing?
It was just another element, but to be honest, it was different. Breathing was different. So every single thing that you did was changed and impacted by COVID. The simple fact of breathing through a mask, which were quite uncomfortable. Everything took a little bit longer at times, just a bit of an adjustment really. For everything that you do, you're more conscious of your infection prevention, and there are a lot of different changes in our processes as well along the way that impacted the nursing workflows too. Sometimes you're more conscious of them, the more obvious things like filling out a form, that's a really obvious change, but then there are other things that are just about which direction you walk in the department changed as well. So there were lots of impacts there.
So Chantelle, just describe a little bit, because it's probably something you guys don't even think about, but someone like myself, and I'm sure Russell, the ED changed in the way it looked. I mean, even how the ambulances presented, and the fact that you had to have spaces to offload. Just describe a little bit some of those things so people understand some of the adjustments that we had to make in a physical sense to the emergency department.
So one very obvious physical change that we had to implement was walls. And now we know that walls can't be put up straight away without the existing infrastructure. So one of the concepts that we had come up with were they were essentially plastic walls. So there were the physical elements such as that actually changed the department completely. So that's the most obvious one. There were some plastic walls, and as that evolved, we put some more temporary walls in. The ambulances were segregated in terms of their high and low risk status as well, and even in the waiting room, we had a very clear defined spaces for patients that may have been at risk of having COVID and those that were lower risk of having COVID. And going 3 floors up, that's another huge change. The impact that had, and the amount of steps. I think everyone had their fitness trackers on and had definitely clocked up the steps by the end of this second wave.
Oh, great. Yeah, it's interesting because they're the things that people don't see in a way. We talk about the care we give, but the actual physical changes that we've had to make to a facility that's a bit older, like Footscray, have been quite huge. So, and so just as I'm going to flip around a bit to that, Russell, and say to you, so we're building a new Footscray Hospital, and we're building, hope to finish the Sunshine ED refurbishment. So what kind of things have we learnt about managing COVID patients or highly infectious patients, and how have we adjusted how we've approached our new facilities or used the opportunity to make some changes?
Yeah, I think we've learned a huge deal, and I think it's probably fair to say we're still learning. We're distilling the lessons into action points that Ainslie and Chantelle have described about how you segregate a high risk or a low risk flow, how you can offload an ambulance into those and keep them separate. How, at Footscray we created plastic walls because creating real walls was somewhat of a challenge. We really focused on how we get airflow in and out of those areas, and how we can put in, negative pressure zones, and actually be able to scale things up and down. And I think, all that really hard-won learning, as you were saying at the beginning, Sue, Western Health has been probably the busiest health service in the state, and by default the country now, in managing COVID patients, and suspected COVID patients for that matter. So I think we've really been at the sharp end and got a lot of very powerful and quick lessons about how we protect our staff and our patients, and by default our community. So it's been really positive to go and talk to government and the department about, these are our learnings on the fly, so to speak, that we're sort of embedding, and we want to put them into our new facilities, because it's pointless building big spanky new buildings and actually not learning lessons and making them sort of, I'm not going to say COVID proof because that's too much of a kind of hostage to fortune, but at least better than they could be, because we've now had that experience. So Sunshine ED is the obvious one. It's being built as we speak, but government support us to the tune of a significant amount of money to put those lessons in that Ainslie and Chantelle have described about the flows and the airflow and how we segregate in real terms, but also have a functioning department. So it's not sort of you just walk into a wall and you've got to kind of find a new way around. And the same is true at Footscray. We've been able to share those learnings from ED right through wards and theatres, and submit those. And obviously it's still on paper, so whilst the design work is still underway, it's much easier to change things than actually in a physical building sense. So I've been really pleased that government have supported all those learnings that we've got in a really positive way, and we'll continue to search international networks for good practice to continue to build those in, because I think, as we've seen from South Australia and from Europe, there's always going to be more learning coming out that we can continue to evolve and put in until the building's built. We may as well have a fair old crack to make it as pandemic proof as we can. But I think government have been really supportive on that way of taking the hard-won lessons of our clinical staff, who have been excellent, and actually applying that in a real sense to our buildings.
Great, thank you. So I guess we've all in Melbourne and Victoria endured, a really harsh lockdown for 4 months, and we're very happy where we find ourselves. But I guess the downside of that is the impact on mental health for people in our community. And I think it's probably fair to say that we've seen a significant increase of patients presenting with mental health problems into our emergency departments. And Ainslie, I know that you're very passionate about this because you had the opportunity to present at the Royal Commission some time ago about generally how we manage mental health in ED. But I just wanted to see if you could share with our audience some of your reflections about what's happening now, I guess, and what we need to be mindful as a community.
So yes, COVID has had an increase in presentations from mental health. Initially not so, because actually people stayed away from ED initially. But as we've seen the presentations come back again, the patients come back to emergency, we've seen a higher proportion of them being related to mental health. And people who have been challenged by COVID and its impact on their life in terms of their finances and their relationships and their purpose, but also people have lost their support networks, and they've lost their face-to-face with their healthcare providers or their other support people. And so what we're seeing is increasing numbers, but in particular increasing severity of presentations and increasing in patients needing admission. And that's had a really big impact with respect to COVID. So if you can imagine that some of our most sick mental health patients are really not in the state to factor in infection control into their day, and that makes it really very difficult for the mental health facilities to manage the COVID risk. And so especially early in the second wave, we had a lot of difficulty getting patients into a mental health facility without knowing their COVID result. And yet, as you can imagine as well, the most unwell mental health patient is the most difficult to get a COVID swab on, because it's very difficult to explain to them why that quite invasive and unpleasant test is needed. So there were a lot of challenges originally, and we've moved through that, and the mental health facilities have kind of also developed their structures around to how to manage that risk. But what we're just really seeing is that the capacity of the mental health system is not big enough for the demand. And that's both in the community and trying to keep people out of hospital and manage them healthily in the community, but also for the people who need hospital, there's just not enough capacity for them. And that unfortunately sort of bottlenecks in our emergency department and can create increased length of stay in our emergencies. And Footscray was quite challenged by long length of stay several years ago, and has had a really good last 2 years or so, because they created some extra mental health bed capacity in our local area. But COVID has challenged that, and so we've now seen some increased length of stay in emergency again, which is just not pleasant or therapeutic at all for this, well, for anybody, but especially for this group of patients.
Thank you for sharing. It gives a bit of context of the other side, because I think that as a health service, we've responded really well to the community's needs with COVID, but we can't forget about some of the more vulnerable in our community as well. So Russell, that brings me to, we're managing COVID, at the height of the second wave, we've got 70 patients that we cared for in ICU. So tell our audience a little bit about how we try and manage our business as usual, as well as managing a pandemic.
Yeah, it was.
Makes it sound easy, wasn't it?
Yeah, well, it's said very quickly. Yes, it's very easy. So I guess that the challenge is that healthcare doesn't stop. So even with the pandemic, we were still having, as Ainslie and Chantelle have been saying, people coming to ED for other things. We've had lots of babies being born. In fact, August broke the record, and we had 579 babies born in that month, which was interesting in a COVID kind of way. The group, though, that kind of have had to adapt the fastest have been our outpatient clinicians to support patients out of hospital with telehealth. And that's been very, very quick to sort of catch on. And I think within about 5 days, we'd gone from only 1 clinic on telehealth to 61 clinics on telehealth, and it continues to expand. We've managed to redeploy staff to support people at home in a sort of rapid allied health service going out into the community, because people couldn't come to hospital anymore for physiotherapy, for argument's sake, because it just wasn't, allowed. And I think, we've also seen a significant number of patients that haven't come to hospital because hospitals were fairly scary places to come to in wave 2. And the community still have a bit of a perception of that at the moment. And I think, we did stop doing elective surgery. So those procedures like hip replacements and knee replacements, we stopped doing a lot of surgery because we needed staff to do other things for COVID. And a lot of patients in our community have been waiting now for that. So I think they're doing it particularly tough, and we're trying to restart that in a sensible way to get those patients some treatment. So I think, it's been tricky for patients, but I guess 2 messages for me. One is, I think, as Ainslie and Chantelle have said, even though our staff were understandably concerned their colleagues were getting ill with COVID, we live in our communities that we work for, the incredible nature of the health service staff to continue to come to work and support patients and their colleagues was phenomenal. No one sort of walked away and said, that's not for me. Everybody put their hand up collectively and said, how can I help? What can I do? My role's changing. I'm going 3 floors up, but it was really positive to see that. And I think equal to that, our community have been an incredible support to hospital staff. They've, been unbelievable in their support around understanding, changing and visiting or no visiting at certain points, which is really tough, I know. They've supported us with face mask making and surgical scrub type making. They've donated food in incredible quantities. So I think, the whole community and health service response has been, remarkable considering what we've all been dealing with. And I think, as Ainslie said, the pressure of homeschooling, lockdowns, masks, all those freedoms we take for granted disappeared. And we were probably quite fortunate we could escape from home to come to work. But it was tough for a lot of people. So to get that support from staff and community has been incredible.
Thanks, Russell. So if I asked you to reflect over the last 7 months, what surprised you about, Western Health's response, maybe even your own thoughts and processes around managing a pandemic as a CEO?
I think it's not so much that surprised me. I think it was really heartening to see that like every jurisdiction in the world, we're no different. Healthcare staff, rose to the occasion and put their hands up and said, how can I help? Whether that was, delivering PPE, working in the community when they used to work in theatres, or, whatever that was. Even, our support staff were incredible, continuing to work from home, or, come in and support ward clerk duties, etc. I think, everyone came to work, the cleaners, the food delivery guys. And I think, it wasn't surprising. It was really heartening to see that. And I think, just that shared ownership of we're here for our community was great. And I think we've all had to sort of grapple with what does COVID mean for us and how do we come to work? And I think Ainslie said it, how do we remain safe and support each other by, having that standard of how we do things? And I think, washing hands in healthcare services has never been as prevalent as it is now, but I think the community is starting to understand some of those key messages. And I think that's been really positive for me about how the community and health have pulled together. We've all done it tough. I think the community done it tougher than us. But actually collectively that action is paying off to get, I think, as you said, Sue, where we currently are coming out of some of those restrictions and moving to a new COVID normal, so to speak. So I think it's been hard work by a lot of people, but I guess the flippant part of me says that my job got really easy because I went from lots of projects to COVID. Now my life's getting way more complex because all those other projects have come back with a vengeance. So I think that was a good reflection, how we can go single focus and deal with that and then sort of, revert back to stuff as we go. But
Nice. So if I asked you, Chantelle, but what's your thoughts about what surprised you in all of this over the last 7 months?
I'd have to probably agree with Russell. It's not so much as a surprise after having worked for Western Health for 11 years now, the resilience of the health service and how we were all able to adapt and be dynamic and be flexible and take on any challenge that came our way. And like I said, that, it really didn't come as a surprise because just knowing the culture that we have at Western Health and the support that we have from our community and from our colleagues, I think that was, really stood out to me.
Great. And Ainslie, you?
I think the same thing. I was incredibly proud, actually, of our group. And, if anything's going to test you at something like this, and it just shows the hard work that we put into all of the things prior to this. We, put a lot of hard work into building trust as leaders within our department and listening to them and responding to their concerns way before COVID. And so then when COVID comes along and you really have to change tack, it's less collaborative, let's be honest. It's more about telling people what's required, making decisions really quickly with very little stakeholder engagement. But they realised that we had to do that and they came along and they trusted us. And I was so very, very proud to see that put in place. All of the things that we've worked hard for came together. And we have learnt things that we will now continue. And we learnt how to have strong sort of governance for our department as well. We learned how to have strong communication. We learnt the power of like pre-communication almost and getting in front of the chatter and the rumour. And those have all been really powerful learnings for us as well.
Right, that's great. And Russell, I might get you to channel Marion a little bit, Dr. Dr. Marion Kainer, and you know, what is it, do you think, that will stay with us now for quite some time in our practice as we deal with the new COVID normal, to use the jargon?
Yes, I feel a bit of a fraud impersonating Marion. I'm sure she'll tell me off, but I think it's, you know, part of it's around that messaging that we've learned about what works to, you know, defeat the virus, so to speak, and the fact that, you know, hopefully a vaccine is coming. There's some great news about how effective they are and when they might start to roll out, which will be great. But I think it's those key messages that community really got very early on and complied with: the wearing of masks, the washing of hands, the good personal hygiene around contacts. I think that's been the key bit, and I think part of the challenge now is not getting too complacent and running before we can walk. We're on a very careful path that the government have kind of set out. We may or may not agree with that. It's not for me to comment, but I think it's about how do we stay the course and make sure that we don't suddenly rush into a space where we get a third wave through an accidental kind of outbreak because we had a mass gathering and off it goes. And I think communities challenge almost as we get closer to Christmas and we kind of in this new normal, it's a bit confusing. And I was commenting today that I was out with friends for the first time over the weekend and went to a sort of a restaurant, and it felt really odd to be sitting there without a mask on, talking and eating and drinking, and then going home, but you put your mask on when you leave the table. And it just felt a little bit strange after 7 months of not doing that. So I think it's about how we don't get too complacent and still kind of comply with the rules as they are. But I think for me, it's that core message about, and I say it was a joke inside the hospitals, that hand washing, you know, got to 100% in days and stayed there, which is what we've been chasing for many years, Marion would have said. It's how we keep that there and make sure that as community we can't do the same things. You know, I don't think hand wash has ever been as prevalent as we're seeing at the moment, and that may be a great thing to continue.
So one of our, I will open the questions shortly, but I've got a couple of questions being already put up. And so one of them that ties in with that, Russell, is it says, how do you make sure the positive changes we've made remain entrenched once we go to COVID normal? And I was thinking about our telehealth and how much work we've done there quickly. And so it'd be good to hear what we've done and how you see that. Will we continue to work in that way, I guess, is one example.
Absolutely. I think telehealth has been talked about in healthcare for a long time, and we're pretty slow at adapting to things and adopting that. We're a very conservative bunch. But I think the drive of having to work very differently really energized that push. And our clinicians certainly grasped the nettle with both hands and sort of ran at it. And I think that will stay for specialties that can do that safely and meet patient needs, because it's an awful lot more convenient for our community. The best story I heard over the lockdown was a truck driver who was a patient who did his Zoom from the side of the Hume Highway because he was off delivering essential supplies somewhere. But he could pull over safely, have his consultation, and then get back on with his delivery to Shepperton or wherever he may be off to, because it was convenient for him. And that was great. It didn't mean he had to not miss a day's work or come into the hospital and sit around. So I think that real convenience of the telehealth is important, but I think it's worth saying to people that are listening that there's an awful lot of governance gone in around the telehealth to make it safe, both for our clinicians, but importantly for our patients. And I think all of the planning that we've done since launching that has been about how do we make this the safest it can be to meet patient need, but also make sure it's not going to cause harm. And not every clinical presentation is going to lend itself to telehealth, but a lot do and a lot will. And I think that's how do we support our patients have that choice. And some people may love it and some people may hate it, but it's about how we offer that. So it brings a convenience to patients that wherever you are, you can get your consultation, you can dial in, have it and leave, and then get on with your daily business without taking lots of time off work or trying to find a car park at a hospital or stuff like that. So I think that's been a really positive for me about that ability to turn that on a strong governance way and protect people, but offer that flexibility of service.
Great. That's a great story about the truck driver. So I am going to open now, I'll sort of rest you a little bit, but I'll direct questions to you accordingly. And so I will open the questions to our audience and suggest that they can go down to the lower bar on their whatever device they're watching on, and they can enter some questions in the Q&A section. And while we're allowing people to do that, I have had a couple of questions earlier. One of them is a good question, and it's about the fact that they've heard also from you, Ainslie, and Chantelle, that some of the stress for staff, the fact that they've had to deal with family life and do that juggle. And so the question is, you know, what are we doing to help our staff? Did we increase support in the health service? Now, I potentially could answer that myself, but I thought it might be nice for me to hear from you guys whether we got it right or not. So over to you, Ainslie. What kind of things did you do in your department, and then what kind of things possibly you might have tapped into what you knew was going on as well?
So one of the things I'd say first is that emergency departments are a massive family, and so a lot of the support came from each other. We really prioritised regular communications, and I suppose we'd probably call them touch points with staff to make sure that they felt part of the team. We did some novel things, so some COVID safe activities, and probably one of the things that COVID really impacted was the social atmosphere that we had at work. And, you know, we were off in the department to have cakes and parties and things like that. And all of a sudden, not only could we not do any of that, but we couldn't even eat together. And so we had to find some COVID safe activities, and Chantelle championed some gift packs for staff. And we had a COVID colouring in competition, or it wasn't really a competition, but it was a group colouring in activity, which actually started with people telling me the things that they thought about COVID. And so we had things like toilet paper on there and, you know, hand hygiene and things, and we coloured it in. It's now something we can keep on our wall in A0 size forever. So we really tried to sort of keep the team together in novel ways. And Chantelle might have some other stories about how, you know, we've utilised the Western Health frameworks as well.
So Sue Ellen and the team and the foundation team put together a really lovely wellness hub. And, you know, we've all had access to that area. It was a safe, quiet area where we could take some time out from, you know, the PPE, from the busyness, and you know, just take a real break from work for a minute. And so many of our staff used that and really, really enjoyed that space. That was the place as well where we got to go and pick up all the donations of food and, you know, all the community gifts. And, you know, every couple of days we'd get an email saying, please come and pick up your goodies. There was staff there that we could talk to. There was the employee assistance program, and, you know, just the camaraderie in the ED and at Western Health was really, you know, speaks for itself in the way that we dealt with it. But there were always these, you know, the extra things that were provided to us from the health service that really made a difference to our day, really. And never have I felt more valued as a nurse until this time, from the community and from our colleagues. It's probably the most valued I've felt personally in my career. So that was really lovely.
That's great. Lovely to hear, Chantelle. Russell, the questions come in about, I guess, people are hearing that patients have put off seeking treatment, like for cancer care and other illness. And so is that really the experience that is happening to your knowledge?
I think it is. Looking at the statistics, certainly they're very significantly lower than normal. So cancer diagnoses, we can usually say, you know, within a certain month you expect X number of patients from a population to come through with these diagnoses, and it's significantly lower and has been across COVID than we would normally expect. So the concern is that the media and the health service are calling it deferred care, but people have chosen to kind of not come to hospital to get tested because they were scared of, you know, getting COVID or coming out the house and breaking the rules. So there is a concern that patients have been managing and putting up with things that ordinarily they would have been seeking treatment and or, you know, diagnoses about. So I think there is a challenge for healthcare across the state that, you know, that will come to be that there are more patients that will need greater interventions because we're going to find them that little bit later. And I think, you know, for community that are on tonight, you may have seen on the radio and the TV all of the advertisements around screening services and bowel cancer and cervical screening, trying to get community to come back and seek that diagnosis. And I think it's been hard for community. Hospitals have been kind of no-go zones. Primary care has been a lot of telehealth and telephones only, and a lot of confusing messages probably for people to cope with about when do you leave home, when do you not leave home. So certainly as a health service, we are concerned about what people may be sitting with and not seeking help, and we're trying to encourage them to come in, and hopefully we can catch things still early enough and give them good news rather than bad news. But it is a definite concern, absolutely.
Thanks, Russell. So I'm appreciative of time, and so we'll probably there's no more questions on the line, so we'll draw our webinar to a conclusion. But I want to thank the panel members very much for their time and the information they've shared. It's been great. And Julia will pop back up as magic does with technology, and I'll let her wrap up the session. So thank you, guys.
Thanks, Sue, and thank you very much again to all of our panelists. It's so valued hearing all of the work that happens, and for somebody who works within the health system but not necessarily as a health practitioner, just the enormity of the job that's been done by the entire Western Health team this year has been phenomenal and quite humbling observing that from close hand. So thank you to you, and thank you very much to all of our donors and supporters who've been with us along the way as well, and for your support too. Thank you so much for sticking with us, and hopefully we'll have a much better year in 2021. That'll be great. Speak to you all soon. Thank you.
Thank you.